Perfect. Excellent. Thanks, Lee, for the introduction. And for those who haven't met me, I'm Roby Bhattacharyya. I'm an infectious disease doc at Mass General, and I talk about COVID to you guys kind of a lot, as Todd alluded to. And as usual, I have thoughts as we head into our third full winter in the US of COVID. And so I'm going to dive right in and talk about where things stand now, and a little bit on new developments that have happened since September when we last had this conversation, and then end with some thoughts on gatherings during the holidays, including the Broad Retreat that's upcoming. And I'll say that I'm actually double booked today, and we'll have to jet after this, but I'm happy to answer questions on the Town Hall Slack channel. They'll probably be a bit asynchronous, but that's the beauty of Slack. So please put your questions in, and I'll answer them today. So to start with, where are we now in the country? We're in kind of an interesting place. I alluded to this last time, and it's still true in this long, slow, basically plateau of cases this year that's higher than any of the prior sort of intra-peak plateaus that we've had. And it's actually a little bit lower in terms of measured cases than where we were at this time last year, but we know we're testing less and certainly reporting fewer tests than we used to. But hospitalizations and especially deaths are much better than they've been. You know, a year ago at this time, we were 4 months into what was an 8-month stretch of 1,000 deaths a day, every single day, for 8 full months. We're about a quarter of that now. That's still a lot of deaths from a single respiratory illness that, you know, extrapolates out to 100,000 a year. That would be a very bad but not unheard of flu season. But we haven't even gotten to the teeth of winter yet, right? So normally we would expect like flu to get worse from here, and I will come to this, but I expect COVID to also in terms of at least case counts. So while cases are about where they were, deaths, severe disease is down. I think that's due to the population immunity that we've accrued. I think it's worth thinking about who are among those 260 deaths a day. Even more than it's been historically, it is the elderly. It's like more than 90% of deaths at this point are over 65. And even among the elderly, it is disproportionately those who are not vaccinated and those who are under-vaccinated, not boosted. And that's despite the fact that many of them have had COVID before. There is still this clear distinction between by vaccination status. So this is still the most important thing that one can do to reduce the likelihood of severe outcomes from COVID. Looking at Massachusetts, the story is pretty similar. We've seen fairly steady cases, hospitalizations, and deaths, an uptick lately in test positivity rate, which I think is a real signal. And the one other thing I've noticed on the Massachusetts dashboard that I don't have a great explanation for is severity has gone up a bit since last time I looked. This used to be, last time I collated this, just about 3 weeks ago, this was a quarter of patients were actually admitted for COVID. That's actually gone up to a third. There are 40 or so patients in the ICU and 8 on ventilators, and those have both gone up a considerable amount. Not entirely clear why that would be, but it's something to keep an eye on heading into winter. And then if we look at wastewater shedding of COVID, I think this is a better way to look right now, actually, because it's not dependent on testing and reporting behavior. And that's telling a tale that's similar, but I think wastewater amounts are a little bit higher. So we're at the same level as we were at this time last year, rather than a little bit lower. We're actually 7-fold up from the best we've been this calendar year, which was after the Omicron wave swept through, but still 10-fold or more down from the peak. But we've doubled over the last couple of weeks. And this is in the range, sorry if folks can see this in the auditorium, but this doubling that we've seen over the last basically week is in the range of blips we've seen all year, but because it's coming after a Thanksgiving holiday when I kind of expected this, I think that's real and likely to continue. I hope I'm wrong. But let's talk about seasonality. Building on that, I've mentioned that I think this is going to go up in the winter, and there's a little bit better evidence since last time that I thought I'd highlight. It's kind of a cool study out of the group from the CDC and the Emerging Infectious Diseases where they looked at other coronaviruses. So there's 4 other seasonal coronaviruses that circulate. They cause common colds. And they looked at the seasonality since 2015 in a higher resolution than I've ever seen before, and it's really striking, the patterns that these take. Other than the first winter of COVID, when things were a little bit delayed, you can see that over here, they basically all go up in late November, peak in late January, and come back down by like early April. This is coronavirus season. It's probably a combination of weather, which affects the virus, particle stability. It affects our immune defenses in our respiratory tract, the temperature of the air, and then it also affects how we behave, right? And an inseparable part of that is how we behave around the holidays. It's not just how we behave when it's cold, but it's how we gather on Thanksgiving and then one generation time apart on Christmas and New Year's, right? Like this is how we are and this is how we're gonna be, and this is gonna have predictable effects on the circulation of viruses that we share through air. And so if you overlay that on the coronavirus trends, there's a lot of undulations that we can't explain, but I think it fits really well with what we've seen each of the past couple of winters. And so I expect this to happen again this winter. I think it's something we should keep in mind. I think the consequences of that will be lower in terms of severe disease, but I think cases will go up very soon. The other thing that's happening this year is there are other respiratory viruses circulating. There's flu and there's RSV, and they're really in high gear this year. And at an atypical time. Those are actually usually pushed to January, February, March. They've come early this year. It's not exactly clear why, but probably related to the behavior changes we've seen the past few years. And these can be, every year they can be severe for young children. And I've seen no evidence that the rates of severe infection are higher this year, like per infection, and kids will mostly do well, but it happens every year that kids get very sick from these. And that's happening now to the point that our pediatric hospitals are really quite full. So the best things to do about these are to get your flu shot. It's actually really well matched this year to the circulating strains, which is basically just luck, but good news. So get it, have your kids get it if they haven't already. COVID boosters will help too. I'll come back to that in a minute. And although it's not available yet, stay tuned for future years. There's really promising news about an RSV vaccine that people have been working on for years to decades that's not going to be available this year, but maybe in the coming year or two. And we've also learned, for what it's worth, that masks and distancing really decrease the transmission of both of these viruses, right? They basically didn't happen in 2020 and started to come back in 2021. So should we need to as a society? I don't know how we turn that knob from a public health side, but these are controls that we have that are behavioral, should we choose to use them. Variants, really quickly, there's actually not a ton to say here. We're more than a year into the Omicron era now. And since the last time we spoke, it was when it was all BA.5, there's been this, what I call subvariant soup that's emerged. And it hasn't really had a tremendous impact on transmission, which I think is good news. It turns out that under the hood, this is what a lot of other viruses do too. This is why we're continuously getting common colds. They just sort of evolve to evade their latest immunity, and this is now happening with this Omicron scaffold. There's a fascinating paper in PLOS Pathogens that goes into this a little bit for one other human coronavirus that I don't have time to do justice, but there's a citation for those who want a really good read. The biggest impact is on our treatments. Monoclonal antibodies, unfortunately, basically don't work anymore. And this most affects the immunocompromised among us. The last one that was being used for treatment was just withdrawn by the FDA and the company because it's no longer effective against the dominant variants now. It was still working against BA.5, but not these new ones. And the one that we've used for prevention, this combination monoclonal, is likely ineffective based on in vitro data also. Small molecule therapeutics that don't target spikes, so remdesivir by IV or Paxlovid by mouth, those should absolutely still work, but there's some complications with dosing them, and they need to be given fairly early in illness to help. So this is a downside. This also affects the vaccines a little bit, right? So I'll come back to that in just a second, but we've learned a bit more about these variant boosts, and I wanted to go over that quickly. You may have heard in the news there's some conflicting data about whether the switch to the new BA.5 vaccine that I talked about last time was the right move or not, and there's actually both of the companies who have studied this as part of trials report that they are getting much better boosts in neutralization against BA.5 with the new vaccine than they saw with the old one. That would be good news. There's a couple of other studies on sort of more randomly sampled patients from very good virology labs that show that there's actually no difference between the old vaccine and the new one. But it's important to dig in, and there's been some negative press around that. I think it's important to dive in. Actually, every single one of these showed a similarly great performance for the variant boost. The difference was the variability in how the old vaccine went, and I think that has to do with just infection histories, who had Omicron. I think people in clinical trials with companies are generally more careful, and there's probably a less background infection rate. So I think it's very, very clear that a boost helps compared to no boost. You see sort of like 15-fold increases in your ability to neutralize this new virus. So boosters, I think, very clearly looked like they were going to work, and we now have some efficacy data. Again, in the interest of time, I won't go too deep, but there was a case control test negative study of basically 360,000 people who came to clinics around the US looking for tests for a respiratory infection. 120,000 of them ended up having COVID, and you can look at who was vaccinated and who wasn't among those who tested positive versus negative. It's a pretty good and careful observational study design. And what they found was a 30 to 50% efficacy of the booster compared to people who were already vaccinated. And this was true whether those patients had 2, 3, or 4 prior doses of vaccine. For all of those people, a boost reduced the likelihood of getting infected with COVID. The longer it had been since your last dose, the closer you were to 50% rather than 30%. So this is not like the world-beating 96% that we saw, but this is mostly because everybody has a lot of immunity here, right? Like this virus on its own is just shooting through societies. We're seeing that in China now, and it's not doing that here because we all have immunity now. And so to improve on that immunity is really quite impressive. And so this can drive cases down. It's not going to be a magic bullet, but it's going to help. And no sign of that waning over 2 months that that study was done. It certainly will wane. This won't be good forever. I think we've learned that about coronaviruses. But at least for 2 months, we can get protection from this booster that gets us a long way through winter. Everyone over 5 is eligible if you're more than 2 months from your prior boost. And there's 40 million of doses of this given now with no new safety signal. So I've got mine. Everyone who's over 5 in my family has as well. Winter gathering. So the last thing I want to talk about, and I've shown this before, I sort of tweak it each time, and I don't want, this is sort of how I think about gathering at a time of high incidence. And I don't want to go through all of the details, but they're sort of color-coded by what you can control and what you can't. I've sort of broken it down now by what affects severity if you are infected versus your likelihood of getting infected in the first place. Vaccines actually belong in both sides of that line. And if we focus on the retreat, there's a couple things we just can't control. It's going to be an indoor retreat, and it's going to be a large gathering. There's probably going to be COVID there statistically, right? We're getting thousands of Brodies together. Chances are someone there is going to have it, and so you should just behave at that retreat as you would if you knew that was true. And what can we do to control our risk? Well, some things we can't control, but you can know about and sort of change your behavior. If you are immunocompromised, you're probably going to be viewing this retreat differently than you're not. The other thing I think about is, who am I going to see in the next 2 weeks? Because that's about how long this can kick around, incubate, and then I can shed. And so if you have holiday plans, that might affect the way that you think about this. Testing, we've suggested, and will really decrease the likelihood that someone shows up with a floridly positive, like shedding a ton of virus. If the more folks that do that, the less COVID will be at the retreat. We can't do much about case counts other than know them. We can't do much about ventilation, except that know that the Heinz Convention Center is a large, high-ceilinged place with good ventilation, I am told. I don't know the specs on that. And then we can mask. And I had this low on the list, but the truth is that with the right kind of mask, with sort of N95 or KN95, this moves pretty high up. You can control your risk pretty well if you want to do that as an individual with a high-quality, well-fit mask. The caveat to that, of course, is when we eat, because humans need to eat, and our respiratory tract is near the part that we use to eat, right? So we can't really avoid that. You can control sort of time of exposure. You can, if you're really concerned, if you're immune suppressed, you can eat at a different time than everyone else. You can go out sort of off to a different place and increase the space at the time of that. And so there are still ways to control your risk, but we're in a place where society's gotten to a place where we're mixing. And so I guess the thing I'd say is consider the risk to yourself and those around you in the next couple of weeks. If you're going to mask, consider a higher quality mask here, and sort of do what you think is best for you and support others to do what they think is best for them. And also, this isn't what you should be thinking about ideally at the retreat. This is in the back of my mind a lot, but hopefully we can go and have fun. These really are, I totally agree with Todd that scientific meetings, which I've started to go back to over last year, are just tremendous, and I miss them terribly. And I think I'm really looking forward to the retreat. So that's basically it. I think we'll see cases go up. I expect that to be much less true than it was last year when we had a brand new kind of virus. I also expect that the average severity of cases will stay low because of the sort of hard-won population immunity we have. I still think we're in kind of an in-between phase. And so if it feels uncomfortable, it feels uncomfortable to me too. I think it's going to feel that way for a while. This wasn't going to abruptly end. This is going to, I think, gradually get better, though, I hope. But I've been surprised a lot, so I'll keep watching. And I will look for your questions on Slack. Thank you very much.